Hello, and welcome to Researcher Revealed. I'm Dr. Rosalind Austin, host of this podcast that goes behind just the name that's on a paper or a conference proceeding in order to find out who they are and why they do research. On today's episode, we have a very special episode because our guest today is the Nurse and Allied Professionals award-winning abstract and presentation from the European Society of Cardiology's Heart Failure Association Congress earlier this year in Belgrade. I invited Stephanie onto the podcast after meeting her in Serbia to tell us a little bit more about her journey into research, as well as what her award-winning research is all about. So it's my pleasure to turn it over to Stephanie and our conversation about her journey as a nurse into research. Hello, and welcome to Researcher Revealed. On today's podcast, we have a very special guest. Stephanie, who is a heart failure nurse, has joined us to tell everybody about her research and her research journey. Stephanie, can you tell everybody what you do and where you're from?
Yes, of course. I'm Stephanie. You can call me Steph. I don't mind. I have other nicknames as well.
Okay.
Which I'll keep secret.
Oh, now I want to know.
No, it's from college friends. It comes out every now and then. So I'm an advanced clinical practitioner in heart failure and palliative care. I've been doing that for 2 years in Coventry and Rugby.
Oh, nice. I've been to Coventry once. For the bank conference, I think, the British Association for Cardiovascular Nurses. It's such a pretty place. I really enjoyed it.
Are you sure? Rugby is, I live in Rugby and...
Oh, no, not Rugby, nice. But I was in Coventry, Coventry, the city.
Yes. Well, it was bombed during the war.
Yeah.
And it's been rebuilt, so... And it was the city of culture, so...
Yeah. Yeah, no, I really enjoyed it. I found it really pretty. I went for because of the conference, I went for an early dawn walk. And it was just really pretty having the sunrise through the ruins. And then I went up to the canal basin and all the reflections on the canal. I liked it. I amuse easily though. Anyway. Let's not talk about travel because that's not what we're here to talk about. We're here to talk about research. But before I start going into the research that you've done and that you recently presented at some conferences that I got to meet you at, we're going to start with the Rapid 11. Are you ready?
Yes.
Are you a Windows or Mac user?
Windows. I don't know my way around the Mac at all, but I do have an iPhone.
Ooh, controversial hybrid.
But never used a Mac. My boys do. I think it's a generational thing.
Might be. Do you drink tea or coffee?
Definitely tea. All the way. Yes. And particularly Yorkshire tea.
Yeah.
It has to be Yorkshire. And it's getting stronger and stronger. I don't know whether that gives you more caffeine, but it has to be like an orange colour. And the worst in the world that I could ever be given is a milky, weak tea. Definitely not.
So definitely remember that. We'll have to when we meet up at a conference, we'll have to go for a proper cup of tea somewhere.
Yeah, Yorkshire all the way.
Yeah, fair enough. When you're writing, so whether that was putting together a conference presentation or other work that you need to do you prefer to work in silence or with music?
I'm definitely a silence person.
Okay.
Yes, I've all the way through A-levels, GCSEs, could never have music or background. I've never been able to do that. So, and even if I'm stressed or whatever, I need silence. And I'm thinking about those loop earplugs.
Oh,
not a plug or anything. I'm sure there's other earplugs, but just
this isn't the BBC. You can be partial.
But just because I do like silence to concentrate.
Nice,
Mhm.
nice. Very interesting. Where do you tend to work? At home or at the office?
At home.
At home.
Various places. The kitchen table was my thing during studying, but I've got a little office upstairs
Oh,
in a spare room now, and I've got this little, but it tends to have washing in as well, so it's multi-purpose.
fair enough. Fair. I think pretty much a lot of people's home offices are multi-purpose. What time of day would you say that you are most productive? Not like the hour, but like
Yeah,
morning, afternoon,
afternoon.
afternoon.
I
Cool.
seem to peak about 4 or 5 o'clock when I was writing assignments and things for university.
Yeah.
I like the house tidy. Can't work in a
Okay.
mess.
Okay.
So the house would have to be tidy. So if I got up at 9, it'd be 3 hours of housework so that I could sit down and not be distracted by any clutter around the kitchen or anything like that. And then from about 12, and then I'd peak about 4 or 5 o'clock and be really productive on my laptop at that point. When the kids, they're older now, but they were a
Yeah.
bit younger then, used to walk in like want their dinner or something, but they were of the age where I would just say, oh, you have to get it yourself now, because I would always peak around dinner time.
Oh.
Yeah.
It's I find it fascinating listening to when people are more productive because it's such a personal thing. And I think I might be wrong, but I think you're the first parent that's mentioned that you're more productive in like the afternoon period because a lot
Mm.
of people who are parents who do this, do research, they talk about either early mornings or late
Mm.
nights. So very
I think
interesting
because
that
my kids were late teenagers, and
maybe,
I didn't have to look after them
maybe.
at the time, when I was steam was coming off the laptop.
I love how you describe that. Steam coming off your laptop. Speaking of steam coming off your laptop and likely off of you, what is your favorite referencing management system?
Right. So I'd never really got into them. This is
Okay.
total truth. My
Okay.
own system is what I would say.
Okay, so you gotta tell us the
So
secret.
basically, just open another Word document and start putting all your references on there. That's how I did it.
Okay.
Which I know there
Mm.
is much more sophisticated things to do, but a separate Word document and put as you're writing, I was putting them on there.
I
It
think
works for me.
I don't like the thing that I found most interesting is with all the people that I've had on. It's really interesting how shy people get about this question because I wasn't expecting this to be that like thought-provoking or controversial of a question, but it's really interesting the amount of like really senior researchers. So like Prof. Calvin Morley, he doesn't use a system either. He just uses Google Scholar. So if he wants
Mhm.
paper X, he goes on to Google Scholar, and on Google under Google Scholar, there's a cite button. If you press that, it magically will do what you need it to.
Yeah, copy and paste. It's fine.
Exactly.
Yeah.
So it's what works for you, and I find it really fascinating how many different ways there are to do that sort of a thing. Right. Next favorite is what about when it comes to making your graphs, your presentations, your tables, your figures, stuff like that? What's your
Mhm.
favorite program to use for that?
Well, very basic again, Excel.
Nice.
And recently, you phone a friend or
No.
you ask someone else to do it because they have
Oh,
much better skills than me at doing
oh.
these things.
That is like a career aspiration for me is to have a
Mm,
phone a friend option.
well, I've just made friends recently.
I need to take a page out of your book. Right. Next favorite is what about when you're working? Do you have a favorite desk snack?
Oh, well,
Munchies.
yeah.
Mm.
It is chocolate, dairy milk, Cadbury, just plain, or caramel, that gooey. feeling, you know, when you bite in and you've got a gooiness.
Oh.
Just lifts you. You can write a few more words.
Love
Yeah.
it.
There was
Absolutely
quite
love
a
it.
few chocolate bars consumed during my masters.
Oh, very good. You're not alone in that.
No, it really does the trick. Just a few bites and you can carry on.
Yeah, no, it's surprising how motivational it is. Right, next question. When you're planning or organizing, so whether that's your work life, whether that's a research project or a paper that you want to write up or an abstract to send into a conference, are you a pen and paper planner or are you a digital planner?
I've become more digital.
Okay.
But years ago, the whole pen and paper, a spider diagram. Love a good spider diagram. Put your little thing in the middle and off you go with all your ideas, and then you can formulate that. So I love a good spider diagram.
Yeah.
I think it's all in here as well. So I'm going to put a different answer in, that it's all in my head.
Nice.
As well.
Nice.
And then I've become more digital with diaries. My work diary is all digital now. I don't have a paper diary for work. I used to have a calendar on my kitchen wall. I don't have a calendar on the kitchen wall anymore. No, well, that's when the kids had like swimming lessons and that would be on there. But
like a family organizer.
I would really aspire to having a calendar, because I've got a work calendar and a diary and a personal calendar. My aspiration is to merge those two calendars, and I know it can be done, but I just haven't got around to doing that.
Fair enough. Fair enough.
Yeah.
What about the book you're currently reading?
So I do read the Bible every day.
Okay.
Go to church. I'm a Christian, so that would be my number one.
Yeah.
But the number two is also a Christian read at the minute. Bear Grylls has written a book called The Greatest Story Ever Told. And
I've heard of that.
Yeah, and it is on the Times bestseller list.
Yeah.
And it's really lovely take on the bit I've got to is how Mary is describing her journey with Jesus and giving birth to him and all these people visiting and how she felt on the donkey being pregnant. So it's from Mary's perspective so it's a really lovely definitely story. Yeah. So I'm enjoying that.
Oh, very cool.
And Bear Grylls, you wouldn't have expected to have written a book like that.
No, I saw it the other day on social media and I was like, at first, like I looked into it because at first I thought it was like some sort of like spoof or fake news sort of thing.
It's got very, very strong faith. Yeah.
But well, no, I knew that, but it just wasn't what like typically his books that come out, they're all about survival and yada yada, right? And so I was like, what? And so but then I looked into it, I was like, oh no, it's real. So it's already on my reading list. So hearing from you that you're really enjoying it has encouraged me to put it up a few notches.
Just to add, I do audiobooks. So I must actually add in that I'm not reading that book, I'm listening to it.
Potato.
Does that count?
You're still reading it. Yeah.
Does that count?
It definitely counts. I do both. I read and listen to books. It just depends. Like I find because I do so much computer work and screen work with my like reading during the day, I'm not as keen to read in the evening so much anymore, but I will like listen instead, just to give my eyes a break, if that makes sense.
I do think that it is the screen thing. I'm in agreement with you. That's why I've switched to audio.
Yeah. But no, I love books. Right, last question. Before we get into the last rapid question, although this hasn't been rapid at all, that doesn't matter. Is who's a researcher who you admire?
So I've been doing heart failure for 10 years now. And when I first got into it, I went to Glasgow Caledonian University to do a heart failure module. And the lecturer was Yvonne Millerick. And I followed her for the last 10 years in the papers that she's written. And she's senior lecturer at still at Caledonian, but she's now consultant nurse in heart failure and palliative care, and that is my aspiration of, yeah.
Nice.
Yeah.
Right.
She's inspired me a lot.
Yeah, that she's an amazing person, so I can totally understand that, being in the heart failure world. So before we get into talking about your research, I just want to scroll back a little bit. And so you said it was about 10, 12 years ago. You went to Edinburgh. You did not Edinburgh, Glasgow, wrong place. Somebody's going to chase me down for that one. You went to Glasgow and you did the heart failure course as a nurse. So why heart failure and why palliative care for you, and how did that end up leading you into doing research?
Okay. So I come from a family of quite a few nurses.
Okay.
My mum was a nurse, my aunt was a nurse, and when you're asked, as a little child, what would you like to be when you grow up? I didn't really know. I think I used to say nurse, and then I got to like in GCSEs and A levels and picked pre-nursing. I just couldn't think of anything else more. It wasn't that I had a passion for it at the time. I just couldn't think of anything else that I would do. So this seems to be a common theme. Okay, so it was like, I'll just do my pre-nursing. That led on to nursing, and I love people. I'm a people person, so it was a natural fit to my personality. But it wasn't like that's what I've always aspired to be from a very young age.
Okay.
I just literally found myself in it and enjoyed it. So that was fine. And that I did my training in Nottingham. And my first job was on a general medical ward, which I think is a great start for any nurse. Just general medicine, general surgical, that kind of thing. And I particularly remember loving looking after people who were palliative and end of life. I just seem to have that weird. I don't want to say satisfaction, because that's a terrible thing about someone dying, but I had a satisfaction of being there at the end of someone's life so that they had a good death. And I really got career satisfaction from that at that time. So I knew that was where I was heading. It wasn't all about anything else on that general medical ward, but I remember that. And then a friend of mine, she was over in cardiothoracic surgery, and I thought, I'll have a bit more experience. She said, come over and join cardiothoracics. I thought, yeah, why not? I'll give some surgery a go. So joined cardiothoracic surgery, and that's when I then had my children and worked part-time. So I actually stayed there for 15 years. And what I actually loved was all the cancer element, not particularly all the bypass surgery or the valve surgery. I liked the cancer element of lung and esophageal cancer. So I knew I was still being pulled in that palliative direction. And I did in the end apply to be a Macmillan nurse for upper GI cancers. I got the job, but unfortunately at the time they wanted me full time and my children were still little, so I turned that down. And it really broke my heart, because I could see my way into palliative care, but it wasn't the right, it was weirdly blocked. And I believe that you have a destiny and everything comes about for a reason. So that was blocked and carried on. And my first sort of sister on the ward, who is my line manager now, called Jackie Highland, she approached me, said there's some jobs going in the heart failure team. And I thought, yes, I need to move on. So looked into what heart failure is, because I hadn't really worked in cardiology.
Okay.
But cardiothoracic was giving me some cardiology experience. and looked into it and realised how much palliation is actually in heart failure. And I thought, yes, this would fit me very well. I'm jumping out of surgical, but I'm going to something that I've had cardiology-ish experience for 15 years, and this could be my route into palliative care. So took that job, started as a community heart failure nurse, visiting people at home and up titrating the medications in the clinic. And that led to another. But all credit to this line manager, Jackie Hyland, which she's pushed me all the way into masters, non-medical prescribing, and giving me the palliative link nurse role to develop my passions. She's such a great person at developing people and has pushed me. So ended up doing my Advanced Clinical Practice Masters at Coventry University and graduated 2 years ago.
Yeah, congratulations.
So that's how that all came about, from general medical ward through cardiothoracic onto heart failure, and this love of palliative care from qualifying seems to have been realised in my career. So that's how. And so more recently is the NHS England.
Research.
Yeah.
How did that happen?
So obviously, advanced clinical practice, one of the pillars is research. But after I graduated, actually I didn't have a guaranteed job, but we as a team applied to NHS England for their Managing Heart Failure at Home initiatives.
Yeah.
And we put in a bid that was basically a vision that I'd had 2 years before, all about palliative care, written it down, tried to see where we could go with it, but it was sitting there in the background waiting for the right thing. So this initiative through NHS England, we applied, and we were the only palliative care project that they accepted. The other projects were more about up titrations and new diagnosis and education, but they obviously wanted the whole disease trajectory and accepted our bid. So I became AACP in leading and managing heart failure at home project and collecting data. So when you collect data, you have to do something with that data.
Well, no. You don't have to.
You don't have to, but
you did.
But I did, yes. So obviously studying research at master's level, you realise that you could, create this data set into some research. So I suppose not all of the Managing Heart Failure at Home projects has took it as far as I have. They've just submitted their data to NHS England and that's that. Yeah. But we took it one stage further, and the other people who've encouraged me in my career is Dr. Michael Call and Professor Prithviraj Banerjee. They've pushed me all the way, and we decided that with this data that we got from our Managing Heart Failure at Home palliative project, to write an abstract and submit it to conferences.
Okay, so I'm just going to put a pin in that because I want to talk about what happened at the conference. But before we do, I want to just pause for a minute, and I want to talk about, so you've completed your master's. So that's your history taking, your non-medical prescribing, a research component as well. Yeah. And like physical examination, and I think that's the main ones, isn't it? Have I missed one?
Leadership. And management.
I knew there was another one. Leadership and management. So you had sort of an introduction to, in your research module, you would have had some sort of an introduction to data management, research principles, things like that. So the other people who you've mentioned as being key around you, just again, to kind of complete the picture before we talk about what happened with the abstract that you submitted, Those people, are they medics? Are they non-medics? Are they nurses? Do they have PhDs? Like what sort of skill set did you have around you to support? Like, and you said it so beautifully, what you and your team decided to do, which is take that data one step further. So what were the skill sets that you were able to tap into to support you in taking it one step further?
Yeah, so my manager, Jackie Hyland, she's also done a advanced clinical practice, so she understands research. And Dr. Michael Kaul, Prithviraj Banerjee, they're the consultant cardiologist. And actually, Professor Banerjee has got a role in NHIR, and he's written, he reviews research papers and bids and things. And obviously, Dr. Kaul has got interest in research. And so I think what I thought they saw was the potential in me to be pushed. And come on, let's write an abstract. Let's get that submitted to a conference. Let's showcase what we've been doing in Coventry and rugby. And they helped me write and put it together. So it was my very first abstract in January.
So, first ever abstract writing. You sound like you've got a very supportive team around you, which I think is key, because I think a lot of people believe that research is like a solo event, but I believe it's very much a team effort personally. So you've got a good team around you. You've written your very first ever abstract, and you submitted it to 1 conference, 3 conferences, 400 conferences. Where did it go?
So the first abstract about the outcomes of these patients that had this particular heart failure palliative care model of care was submitted to the ESC, the Heart Failure Congress 2025 in Belgrade, and it was put in and magically accepted.
Woohoo! No, it's not magic. It wasn't magic.
I thought it was.
It's not magic.
I couldn't believe it that it was accepted.
So I think one of the things, like, so that's, we've met for everybody out there listening at conference. And I think for me, one of the things I really love about you is your real, like, I don't know what the right word is, but you just were like that. Like 2 minutes ago, you're like, it was magic, and it was accepted. And just like this real spark, this real passion around having those external bodies, seeing credit in the work that you do and the joy that they gave you. And I think that's just such a beautiful thing to highlight. So got accepted to Belgrade.
So yeah, got it. And I must give credit to another person, actually. She's called Fazzy, and I met her through the innovation team here at the hospital. And she crunched all the figures, and I don't think I could have done that. So it's definitely a team effort to get this abstract done. But we entered in the nurse category. I had led this project from start to finish. It was like my baby, really. So it was lovely to be, the lead author and present. And it would be entered in the nurse category. So yes, off we trot to Serbia in May. With my friend Lise Heine, another heart failure specialist nurse. We went together, which was really nice. Yeah, it was so nice. And it was like, I've never been to a European conference. I've only been to the BSH.
Okay, so
in London. This is my first time.
I just want to line these first up, because what we're building to, I think it's really important that people recognize it. So it was your first project, your first time collecting.
My first ever project as an ACP.
Yeah, your first time ever collecting and analyzing data. Yes, you had a crack team around you, but you were leading the project. Your first abstract, it got accepted, and now you're off to your very first ever international cardiology heart failure conference. Okay, so that's a lot of firsts.
No idea what to expect, and saw my name on the programme, and the day before went to check out where I'd be presenting. It's like some sort of TV studio. That's all I can describe it as.
Yeah,
and then
it's very much like a TV studio.
It was like, I thought, oh my goodness, I'm going to be up there. But it wasn't, I was expecting it to be in some sort of side room, but no, people could walk past. It was in a very general public area.
Yeah.
And the lights it was like lights, camera, action. And I couldn't believe that I was going to have to get up on that stage.
But you did.
I also didn't know.
I'm going to take over for 2 seconds.
Yeah.
Because you did, and I was in the audience, and I was there as part of like the social media ambassador team. And my remit was to really try and spotlight and focus on nurse research, because a lot of times, especially at the bigger conferences like HFA, there's like the big like drug studies get all the stars and the attention. And so I'd approached them and said, can we draw some attention on some of the other research? And up you got, and I was blown away. And like, especially now, hearing your story about how many firsts have lined up to get you to that stage, it increases the amount of respect that I had for how you came across, how well you presented, the research that you presented. So very well done.
Yeah. But could I just also say, I didn't even know I was part of a competition.
Really?
I had no idea it was even a competition. I had no clue what I was doing.
So, for everybody out there who's listening, who may not be cardiovascular, who may not have attended an ESC conference, when the first in the process that Stephanie's describing, so submitting an abstract, ticking a box that said nurse and allied professionals category, within the European Society of Cardiology sort of bubble, for lack of a better word to describe it, ticking that box automatically puts your abstract into a different pile, and it's then judged by an independent panel of judges. The abstract is, and then on the day you're further judged in in your presentation to have a winner selected. And so you were one of 4 finalists.
Four finalists. So my first clue that I was in a competition was when I saw the panel sitting there.
You really didn't know till you got on stage?
Not really. I might have had an inkling, but I actually didn't really know.
Well, that's brilliant. That's probably a better way to do it.
Oh, probably, yeah. Probably.
Because then you can't make yourself even more nervous, because I can only imagine you're probably nervous already, being like your first presentation at your first international conference, blah, 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 all those first. But to then, if you would have known, have on the additional pressure of actually I'm being judged.
Yeah.
Interesting. So sometimes maybe it's better not to know.
Yeah, maybe, but there you go.
Okay, so cat out of the bag. I'm just aware of the time, and it is speeding by.
Yeah.
So I'm going to try and speed us up a little bit. So cat out of the bag. You won. Congratulations! You were the winner of the HFA Nurse and Allied Professionals Best Research, Best Abstract at the 2025 HFA conference by the European Society of Cardiology. So I'd approached you and I said, hey, I want you to come on, I want you to talk. And I wasn't expecting because we hadn't met at that point, and I didn't know what I now know about your catalogue of firsts that got you there. And, I think it's really important to spotlight it, because I've had loads of conversations with people who've got the same level of education as you, maybe different levels of support around them, but same levels of education, who say, well, I can't when it comes to research, or I'm not able. And I just think sharing your story is such an important thing to do, because it demonstrates that it is possible. And it's about having that team. It's about having that right person, that right situation. So what I'd like to do now is, yay, congratulations, is so you won. So now what happens? Or what has happened?
What has happened is a whole catalogue of things. I met you. I'm on here. I actually had a queue of people when I got off the stage, and things have come from that, which is really nice. And on the way out, I met Carrie Spartan, who is obviously a renowned heart failure specialist, nurse in London. And she congratulated me, and I've been invited onto like some sort of working stream about palliative and end of life care in England. So that's really good. And well, it might be UK, but I think it's about England. And I've been teamed up with Yvonne Millerick to work together.
Perfect.
I'm so pleased about that.
Full circle.
Yeah, so we might present that at the BSH in November. So some things coming from that. Some best practice. The model of care may get featured, but I'm on the panel to advise. So that's really great.
Wow.
So I presented about the outcomes of 54 patients, and what I've been working on now is the paper, but we've now got 100 patients.
Okay, so more to come then.
Yes, so watch this space. We've nearly finished it actually, so we will be publishing.
Paper coming, and you're going to be sitting on national policy informing boards. So likely there's a high probability that your research and your now expertise that you've developed in this area and your research itself is going to help to inform that. So pretty much very rapid impact from that research.
Yeah.
So what I think we should do is, we've talked loads about your journey. We've talked about how your research led to you being an award winner and the impact that that's likely going to have. However, we've missed one little thing. What was it about?
So obviously we know that advanced heart failure patients have a very high symptom burden. And I think there's a gap between end of life, where community teams, GPs are very in their comfort zone to look after people dying at home, or people end up typically coming into hospital. And this, even 2 years of living with really severe debilitating symptoms of heart failure. And they're quite complex, and people can live for many months with this. And I think sometimes the GPs can get overwhelmed, especially if the kidneys are starting to decline, and also just to try and plan to keep people out of hospital. Time is very limited, and so this model of care that I thought up helps bridge this gap, and it gets a heart failure specialist. And it was very much to do with home visits, not clinic based, because these people can be quite limited in their mobility. And so the model of care was to address this gap in service, where if heart failure nurses or have generalist palliative care skills, and I particularly have that passion to have driven this project forward. So yeah, that's what it was about. And then we collected the data of quality of life.
So just briefly, before you talk about your data, what did your palliative model for care look like for these patients with heart failure in their homes?
So we really wanted early referral. So don't wait. Just don't wait till these patients are literally probably going to die. They need palliative input way earlier. So we need an early referral in, and then it was 2 to 4 home visits. It depended really, and we did incorporate some telehealth. So telehealth platform was used to holistically symptom manage, teach them a bit more if they'd forgotten about self-management, and it culminated then in some advanced care planning, and and talking about resuscitation status and things like that. Then I would see the patients if they needed to, or they would phone me if symptoms deteriorated. And so they had very intensive input, and then it was like I pulled back unless they needed me, and that approach seemed to work.
So even when you pulled back, it wasn't like you discharged them from service. They were still able to access you at any time point. Okay. Just I think that that's really important before and I don't want to tempt you. I do want to tempt you, but I'm not going to tempt you to talk about your 100 patients in the paper you're about to publish, because we don't want to let that cat out of the bag. But maybe if you could just share a little bit of the results that you presented at the conference around how that model of care in that smaller patient population appeared to impact on their care and their quality of life and symptoms and things like that.
Yeah. So researching advanced heart failure patients is incredibly difficult, and getting the data that you need. So we actually demonstrated that using the KCCQ and the EQ5DL, the quality of life questionnaires, that these 2 to 4 visits and follow-ups didn't actually improve quality of life, overall quality of life in the 6 months that I tracked the patients. But there was areas that did improve, such as anxiety and depression. So I think that was a win, really. Yeah. And I think it points more towards that these people have got advancing disease, and with quite few questionnaire returns, maybe we didn't quite get enough data to try and power the research. So, but it's difficult to expect heart failure patients who are palliative and very high symptom burden to do. The NHSE had given us 3 questionnaires. One was about 2 were quality of life, and 1 was personalised care. So expect people to do that when they're quite A, elderly, B, advanced disease, and C, potentially dying. It was quite a lot to get the data back, and I think there was reasons why that quality of life perhaps didn't improve, and there was other trials like in America and places like that where quality of life did improve on their trials. And they had a control group as well, which unfortunately ethically we couldn't do. It was as part of the initiatives that we were doing.
Well, because it was the difference between so the initiative you had was much more about like implementing a new clinical service rather than like a discrete research project. And so 100% you're right. There's certain limitations that then means, because you can't have a control group, because then it's not ethically moral to withhold stuff that is standard care now, or standard care where you were. I find it really interesting, and I'm going to push you a little bit on this, is so what you said that the KCCQ and the EQ5D, don't get me started on the EQ5D. Everybody has to use it because it's one of the nice guideline reporting things, but I really don't rate it. Personally. So what do you think is the important data that we should be asking? And do you think, and this is probably a little bit controversial, do you think that the low response rate that you saw in those initial cohort of patients, do you think that had to do with the fact that maybe those questionnaires weren't fit for purpose and they weren't asking the questions that the patients wanted to tell?
Yeah, true. Yeah, I think they were generic to the whole of the Managing Heart Failure at Home initiatives, where they're 10 sites, and obviously they were a new diagnosis or what, but for palliative patients, there is a patient reporting outcome measure called IPOS, and it asks them, what is your top 3 symptoms, rather than what's your breathlessness like, what's your leg swelling like. And I have done IPOS with some other palliative patients, and the top 3 for one patient was itching, pain, and there was another thing. Now that was what was important to them.
Yeah.
Now the KCCQ probably wouldn't go into
No.
itching, pain, and well. So I don't know whether the questionnaires for future trials should be looked at. I do know that Clea Atkinson in Wales published about heart failure and palliative care and a model of care. They actually did their own bespoke questionnaire, which was actually more simplified. And so, I don't think the questionnaires were quite the right things for palliative care. But if you want to compare to other trials, you have to use the same thing.
It's such a tricky conundrum, isn't it, Stephanie? Because like you can see how not asking the right questions affects potentially the integrity and your ability to report
and to be published
strong results and to be published and all of that sequely. But at the same time, are we asking the right questions? And I think like your situation is a bit different, because rather than it being a dedicated research study within like what they did in Wales, where they would have had like specialized funding and yada yada to develop the questionnaire, yada yada yada, it's kind of comparing apples and oranges. Because what to me it sounds like you did is you had this initiative. There was a national initiative. You jumped on it and you sort of adapted it where you could to that very specific subpopulation of patients with heart failure who have been categorized as palliative or reaching the end of their life. And so you had constraints because of being part of that bigger program. You had to use those tools. Did you do, because I just don't remember, because it's been like, good grief, when were we in Serbia? May. Yeah.
And it's August now.
I know, that's like 10 years ago in my brain now. Did you do any qualitative, or was it just the surveys and like the clinical outcomes?
Healthcare use. Yeah, we tracked healthcare use, and we also looked at cost savings. So I looked at bed days saved through hospital avoidance interventions. And that was quite telling, that the hospital avoidance intervention stopped people going into hospital and therefore saved money. And more people actually died at home through advanced care planning.
And that's what people want, mainly.
So their wishes were, I can't remember off the top of my head, but out of that 10 patients died, so many died, 6 I think died at home. Which is what they wanted. It's
such fascinating and interesting research. And like I said, your presentation was really, really good and really engaging. But I think it, like, being within similar circles within the heart failure world, I think it's like, it's such an important part of people's care. And I think it does get overlooked because people are hesitant. I'm not going to use the word scared, but people are hesitant to enter into these conversations. And so, like,
I think a lot of the conference was about saving lives and people living longer, but not a lot of the conference was about, or how do people feel? How can we give them a better end to their life?
And like, it's, I don't know, it's something that's always sort of like weighed on my head as well, is it's like, especially within heart failure, but not just heart failure, other illnesses as well. There's such a heavy focus on survive. And I don't know if you've seen it or not, but there's a paper by Alpert, and he talks about actually how, while this focuses on how to save lives, how to improve lives, well, how to save lives more than how to improve lives, that people aren't really fully grasping or taking the time to explore and understand, well, what, by extending that life, by giving them more days, what does that look like for the patient? Because if what that looks like for the patient is more pain, more suffering, are we doing them a favor?
I think we are extending life, and then people are living, like I say, with a high symptom burden for longer.
Yeah.
And then they need help through that period of time where they are still alive, but their quality of life, and maybe that's why the quality of life is going down and down and down. That's an answer to the data. Yeah, the data that we found.
Yeah, maybe
you can't improve it too much.
Maybe. I think you've got a very interesting next several years ahead of you, and you probably now have about 15 more questions you want to ask versus having any answers.
Yeah.
So, you already kind of hinted at a couple of things. So you presented this work at another conference.
Yeah, so we put in another abstract about the KCCQ baseline scores of 75 patients. So we're working our way up, 54, 75, and then we're getting to 100. So about 75 patients, and the baseline KCCQ scores. And what did that mean?
Yeah.
What can we work out from this baseline score? And, you could look at prognosis, survival, curves and these sorts of things, and how debilitated, how many comorbidities they've got, how likely are they to utilise healthcare. So that got presented in Manchester for the British Cardiology Society, and I worked with the registrar, Patrick Tran, on that. Made another friend. And it won runner-up.
Congratulations, Holy Award-winning superstar.
Second abstract run was accepted and won runner-up.
That's really cool. Well done. I think it speaks to the quality of the work that you're doing, but also like the spotlight that you're shining on this area that needs more attention and needs more support. Like so many of the heart failure nurses that I know and that I've either worked with in the past or are continuing to work with, they all talk about the lack of these palliative care services that are specific to heart failure. You know, while they might be able to try and tap into generic ones, there's not equal access to a heart failure specific one. And so I think your paper, your abstracts are being really well received because I think clinicians are crying out for it. So that was done. Now you're ponying up. You're going to do 100, and that's going to get published. Well, you're going to submit it for publication.
Yeah.
So everybody who's listening, make sure you definitely go into the description, whether you're watching this on YouTube or whether you're listening to it on your podcasting platform of choice, because all of Stephanie's, like her LinkedIn will be there. And we'll put in links to the abstracts that you can access. I think the HFA one, you have to be an ESC member.
Yeah.
And I'm not sure.
I got an email today about the BCS one. It's just gone on the BMJ Heart today.
Excellent. And is that open access?
Yes.
Okay, so send me that link.
So I think it is. It said free.
Yeah, that's perfect.
Word free at the end, so that means it.
That should mean it's all good. So send me that link, and I'll make sure that goes in this description as well, so that.
I haven't got a LinkedIn profile yet.
Oh, I thought you said you were on LinkedIn.
I had got the idea, but I haven't got around to doing it yet. It's a bit of a snowball. It's taken me by surprise, all of this.
Well, I was going to say, like you're on such a whirlwind, and
didn't realize LinkedIn was such a thing in the nursing world, but it is.
It's only just become, so you're not late to show up. So sort of when Twitter became X and then X became sort of what it's developed into, a lot of people have moved over to LinkedIn, and LinkedIn is now being used more like X was being used. So like you can, so it's very professional, and it's much more, it gives you more text, so you can write little blurbs about the stuff and whatnot. But
I'm going to have to get with the program and be on it soon. So yeah.
You need help setting up, let me know. I'll hook you up. Well,
This is good.
regardless of your...
I was going to give you this title of accidental researcher. I've come into
I
this.
love it. Oh, I'm
All
definitely
my,
going to use
and
that.
that's where I was saying to you in the beginning, I fell into nursing because I couldn't think of anything, and I kind of fell into this, and this is all not planned in my life.
But I think I go back to something that you said earlier, in that you believe that things happen for a reason.
Yes.
Right?
True.
And I think all of this is happening for a reason. And like, whether or not you catch up to it, whether or not you get on social media, none of that is the important bits. The important bits is you focusing on the research, you implementing it, you working with the national groups in order to get it embedded in policy and guidelines so that your impact as a nurse extends past your locality.
Yes.
And that work that you've done, that foundation, will allow other people to build on it. The social media stuff, that's just a way to accelerate it more, but at the speed that you're going, I don't think you can handle it going any faster. Oh, brilliant. So a couple more questions and then we're going to wrap up, because we're getting close to an hour now. So all of this fame and fortune, ha ha, has come to you around this work. Has that now, like, yes, the paper in the works, has that at all, like, inspired you or made you want to do more, like to go on to do a PhD, to do like an actual research project? Or are you like, you know what, this is good, this level that I'm at, and actually maybe now through my collaborations I can get involved with a few more bits, hone my skills, tap into other people. So what does... Yes, accidental researcher, but now that you kind of are one, are you going to stay one?
I think it will always be a feature, won't it? If you're an advanced clinical practitioner, research is one of your pillars. So you're going to have to plough on. It wasn't something I ever planned, but I think it's something that I will plough on through in whatever. I think as a team here in Coventry and Rugby, we're quite innovative. We like to try new things, and there's a few things that we're thinking, even outside of palliative care, that maybe, you know, in the future, if we're doing something new, we'll collect the data and we'll try and publish. We'll probably do the same thing, to write abstracts, try and get it noticed. So I think research is here to stay in my life.
Okay.
If you're an advanced clinical practitioner, you will always have to say that, won't you?
Well, so yes, but research isn't research, especially as an ACP.
What level you're doing it at.
And that's more what I'm asking you.
Yeah, so what level? We'll see what comes along.
You see what else you accidentally end up doing?
Accidentally might fall into a PhD, but I haven't got any plans at the moment.
I accidentally might fall into a PhD, she says. That's the funniest thing ever. Trust me, you don't want to fall into it. You need to properly plan it.
Yeah. Knowing me, I'd probably accidentally fall into it or something.
Oh, probably.
But it's not on the cards. Okay. But working on other projects to collect data, publish, you know, I'd be open to that.
Very cool.
Yeah.
Amazing. Oh my goodness, you were so inspiring and you were so lovely. I've had such a lovely chat with you, getting to know you a little bit better, hearing about your journey. And like, I mean, I think for me anyway, I'd be really curious. My last question is, yes, you accidentally fell into it, but for all the ACPs that are out there, whether they're heart failure or whether they're frailty or whether they're fill in the blank speciality, based on your experience of becoming an accidental researcher, why would you encourage ACP, like aside from it being on the pillar, why should other ACPs do it? What
I think if you've got a passion to improve patient outcomes, improve patient care, this is definitely the way to be tackling it. you can do it in your own hospital, but what about the rest of the world? What about the rest of England, or then the world, to know about what you're doing and helping drive up patient quality improvements in the NHS. So I do think that people should go down the road that I've been, where they get to present on an international stage and get the recognition for all their hard work. It might be nice, you know, I often have thought about, oh, it was great, you know, that picture of me on the stage, but there was 2 years of hard work behind that to get there, with a lot of help as well. So it wasn't just me.
Exactly. And I think like that's come across really strongly in this episode, Steph. And I think like I'm so grateful for you taking the time to share your journey, to highlight and reveal, you know, a lot about what your journey's looked like, the accidental nature of it, all of the support that you've had around you. Because I think that that's the purpose of this sort of thing, is actually to highlight and show other nurses, physios, whoever is out there as a clinician, that you can do it too.
And I think about all the patients that I've spent time with over the past 2 years, and they wouldn't want that to go to waste. They would want other people to have the same service and model, because the patient satisfaction survey was amazing. The patients absolutely loved it.
That's really cool. That's brilliant. Right. I'm going to let you run.
Okay.
Thank you very, very much. And for everybody out there listening, definitely, even if by the time this goes out, she still hasn't sorted out her LinkedIn, the links to her research will be there. Her name is there, so that you can set up a Google alert on Google Scholar or whatever in order to get notified when that paper of 100 patients comes out, because I know I'm going to be waiting with bated breath to see what that has to say. So definitely check out the episode. And if you have any questions for Steph, drop them onto the comment section in the YouTube video, because that'll be the best way to get my attention so I can get her attention. So yeah, until then, thank you so much, and I'll speak to you again soon. Steph.
Thank you so much.
Don't go away. Up next, we have the top 3 takeaways from this week's podcast by Dr. Rosalind Austin. I wasn't joking. When I listened to Steph, her presentation at Heart Failure Association Congress in Serbia, I was really impressed with her data, her presentation skills, and 100%. She's got a brilliant team around her, from people who helped her data collect, to processing the data, to putting it all together. But she herself just has got a really beautiful way about communicating on this often avoided and sometimes classed as a difficult topic, that being people's end of life. So I was really excited to have her on the podcast to get to talk to her a little bit more and find out more about her journey. And she definitely didn't disappoint. She was brilliant. My top takeaways. Number 1, she kept on blaming her use of research and her falling into research as being part of her ACP role. However, we know within the UK anyway that although those pillars exist, there's a wide difference between the interpretation of an advanced clinical practitioner's research practice. And she's definitely taken it to a different level. And I loved how she put it, and these are her words, not mine, is she's just encouraging everybody out there, you know, you're going to be collecting this data anyway in your clinics, especially if you get invited to be part of one of the national programs, and like what she did, you're going to have to collect this data anyway. So why not just take it one step further, get a team around you to help shape that research, and get it put in as a conference abstract. And now she's done 2, and she's writing a paper. So I don't think there's going to be any stopping her or holding her back. She's brilliant. Second takeaway, and I loved how she said this as well. She talked about like her why of doing research, and for her, I think because of her journey, like, yes, she did this program for over 2 years. Yes, she had the right team around her. Yes, her abstract is award winning, but she's been able to see in a relatively short period of time how that research and that evaluation of that service is now she's being invited to inform national policies and guidelines around this type of care, which is much needed in this population. And so for her, this research and doing the data and presenting her results has been a way to massively increase her own personal impact. And I know we've had other guests talk about it as well, as research as a way to increase your clinical impact. But for her, she's actually living that. And her sharing her story is a real example of how putting yourself out there, taking it one step further, can actually mean that you taking it one step further can inform policy and procedure, policy and guidelines. And so I think, be like Steph, take it one step further. Right. Last takeaway, the third one. And I really liked this, and we kind of touched on this a bit in the discussion, but I wanted to talk about it more in this top takeaway is that in research, in order for it to be published within various different populations, within various different sectors, there are, to some degree, accepted questionnaires that you need to do and that you need to include. So EQ5D, as an example. And the EQ5D is an accepted tool around quality of life that in the UK, the organization of NICE use in order to determine whether or not a new treatment, a new intervention, a new pathway gets adopted. So it's an important tool, and it is short and it is brief. But if you're dealing with a very sick population and they have a limited scope of energy, is that the right use of their time? Is that the right questions to be asking them? And is poor response rate related to them actually saying this isn't important, these aren't the right questions? I found it really interesting. And she talked about it, while her quality of life questionnaires had a very bad response rate, and it didn't really show that much, her patient satisfaction questionnaires were really strong results and showed great satisfaction. So, as researchers, health researchers in general, how do you go about deciding which questionnaires to use and finding that tricky balance between the data that you need to get published and to get recognized and the data that's going to be meaningful to your population or meaningful to your question? And walking that line can sometimes be a lot more difficult than what is often talked about. And so I thought at her earlier stages of her research ventures, being an accidental researcher, she's already started to recognize that. And I think for me, my third top takeaway from this is that getting the data that you need can be trickier than what you think it is. Even knowing what data that is important can be really tricky. Right. That's it for me. I've really enjoyed this conversation and getting to know Steph a lot better. I hope you have as well. I know she's definitely inspired me. I mean, to have a master's and to be an ACP and to already be an award-winning presenter of researcher. I mean, I can't even imagine where her career is going to go from here. It's brilliant to see. And I'm very grateful for her time. For all of you that have made it to this far in the podcast, thank you so much for listening. Do leave a comment, reshare this so it gets out there for other people. It helps grow the channel, grow the impact. And most of all, it means the world to me to hear from you all, whether that's publicly on social media or a private message to me. So yeah, let me know what you think. And what did you think of Stephanie and her research? Right, that's it for me. Next episode will be in another 3 weeks. Remember to watch out for the short videos. There are little snippets that I think were particularly powerful from the episode on YouTube. If you're not a subscriber, make sure you do subscribe. Otherwise, you're going to miss out because I don't necessarily put them out on social media. And yeah, until then, keep asking why.